Hi, my name is Rich Bassett with Lehigh Valley MedEvac. I'm one of the flight paramedics here. I've been here for about 15 years, and today we're going to talk about transport of the high-risk OB patients, and especially some of the stuff that relates to in the transport environment. So some of our objectives: a baseline assessment, documentation of the high-risk OB patient, meeting the general needs of the high-risk OB patient, basic understanding of fetal monitoring variability, and basic understanding of fetal distress. Classification and treatment of selected OB complications, and a basic understanding of medications that we might use in obstetric emergencies. Some of the baseline information that we want to get on anybody that we're transporting, if it's not a high risk, we want to get an age, how many pregnancies, how many deliveries they've had, the gestation age by calculation, and that can be sometimes done by ultrasound or maybe a fundal height, or maybe they have, document, when the mom's last period was, and they figure it out from there. Has there been a recent ultrasound performed, which might help, confirm the due date, the placental location, and it also might pick up any abnormalities. As far as using fundal height, usually anything above the umbilicus is going to be around 20 weeks, 20 to 22 weeks, gestational age. And then there's the 2-finger rule, and for every couple fingers, it goes up like another 2 to 4 weeks. It's just interesting to know if you have somebody with a fundal height, maybe like in our environment, or we're picking up at a scene, or maybe a local hospital that doesn't have OB service or something. It's something we can kind of do real quick, just to see maybe, if it's below the umbilicus, it's probably not going to be a viable baby, unfortunately. Just something to keep in mind. I want to get any past medical history of the mom, also any past OB history. Like the types of past deliveries, were they C-sections or were they normal deliveries? Was there any complications with the previous babies? Did mom experience any complications in her past pregnancies? And if there was any preterm deliveries and what those outcomes were. The gestational age of past deliveries might give you a cue, how much time you got, and the length of the last delivery. Did it take 20 hours? Did it take 2 hours? That might be good to know. Is there, part of our baseline is, do we want to know if there's any vaginal bleeding? Is the bleeding painless, or is there some contractions with it, or some pain? Was there mucus associated with the blood, as with the classic bloody show? Did the bag of waters rupture? Was it a gush or a trickle? Is it clear, or was there some meconium staining, which would be like a greenish brown staining, stool from the baby? Or was it really dark, suggesting the presence of blood? Prenatal care, was it adequate, none, or limited? And just to kind of keep in the back of your head, if it's considered limited prenatal care if it was less than 3 visits. Does the patient smoke? Any substance or alcohol abuse? Any current medical problems with this pregnancy? Maybe diabetes, maybe some hypertension, anything along those lines. And were there any diagnostic tests performed to this pregnancy? Find out what those results were if you can. Mother's vital signs, and does the fundal height, we talked a little bit about that already, correspond with the gestation? If it doesn't correspond, that means that somebody's calculations might be off, or it might actually be a sign that there's a complication with the pregnancy. You want to inquire, because we might not all be really that familiar. If we're going to a small community hospital, for example, we're not maybe really, most of us, or a lot of us at least, might not be real comfortable or have a real good idea exactly what we're feeling for palpating for the fetal position. But especially an experienced OB staff person says that they really can't determine by palpation how the fetus is positioned. That might be a clue that the fetus might actually be in a transverse position. So just kind of something to think about if they say they cannot determine its position by palpating. Inquire about fetal movement. Sometimes you can get that from the staff at the referring hospital. Sometimes you're going to get that from the mom. So if the mom tells us or the staff is saying, look, there's really hasn't been a whole lot of movement lately, you might want to think, geez, there's a sign of fetal hypoxia, for example. I think it's pretty much out of our scope for us to do a vaginal exam, but just something to keep in the back of your head. If there is a presence of hemorrhage, vaginal hemorrhage, you need to rule out a placenta previa before anybody does a vaginal exam. That needs to be done with an ultrasound. So maybe if you're with, and somebody's referring ER, and they may not be real familiar with OB type stuff, and there is hemorrhage going on, maybe before the nurse or the doc there goes and does a vaginal exam, maybe I'll just kind of mention to them, hey, did you guys look for a placenta previa before you go doing a vaginal exam? And that could be ruled out with an ultrasound. Especially for a more high risk, and I think it's part of our QA program and QI program, is anybody in their third trimester, they need to have like a wedge or something underneath the right side or be transported in the left lateral position. Usually in the transport environment, we're just going to put a wedge, like some folded up pillow or blankets underneath the mattress, underneath the mom's right hip. And the reason we do this is just to keep the uterus off the inferior vena cava, which could cause a problem with the mom's preload, because the uterus might be resting on there and decreasing blood flow back to the heart. And as we mentioned, anybody in the third trimester, whether they're high risk or not, especially if they're flat on their back, they need to have, they need to be at least leaning on towards their left side. Just some general things: obtain serial vital signs, know patient's temperature, if there's any contractions going on, the frequency, and then the fetal heart rate. For us, we're usually just going to use a Doppler, whether we're in the ambulance or we're in the aircraft. A lot of the resources say when you're transporting these types of patients, that's perfectly acceptable if the transport time is less than 30 minutes. Even if it's greater than 6 or 30 minutes, we're still not going to be able to do it the same way they do it in the hospital. You should have, especially if it's an at-risk mom, at least one large bore IV established. It could be ringers or, I believe, saline, running at least 125 an hour. And the fluid rate should be based on the patient's hydration status. Also consider your renal, your cardiac, and your pulmonary status when you're changing your fluid rate on mom. For the high-risk OB patients, they should have some supplemental oxygen, especially if you notice that there's a problem with the fetal heart rate, or if you're being told there seems to be a problem. Fetal heart monitoring, especially in the hospital, they also monitor when the contractions are, as far as what they monitor, and that's really when you should see some changes with the fetal heart rate. It actually could be a problem if you don't, and we'll get more into that in just a little bit. When they're doing the fetal heart rate monitoring in the hospital, they get a baseline over a 10-minute period. And the baseline fetal heart rate should be between 120 and 160. So when you talk about a baseline, it's really an average over a 10-minute period of the fetal heart rate. Now, for us to try to get an average over a 10-minute period with a Doppler, that's really not going to be possible for us. That's something that's going to be told us when we're picking mom up from the referring hospital. We already talked about how we use a fetal Doppler. It's a choice for our portable one for assessing the fetal heart rate. In the hospital, sometimes the electronic fetal monitoring is sometimes accomplished through a wire that's actually connected to like a little spiral needle that's inserted into subcutaneous tissue of the infant or the neonate. And so sometimes that wire doesn't always come out. Sometimes the patient might leave that unit, maybe even going to the OR, or maybe even be transported to the hospital. The wire will be disconnected, but that little spiral wire still might be, it's usually attached to the neonate's scalp. So if you see something like that, if you end up having to do a delivery, don't be too freaked out about that. You can usually be easily removed just by turning around. You can just leave it in, actually, till you get to where you're going. Fetal heart rates often change in response to stimulation, and that's actually a good thing, like if the kid's moving around or during contractions. Variability is one of the single most important factors in predicting fetal well-being. That is something that the variability is going to be hard for us to tell in the transport environment, but that's something we might want to ask if we're picking up mom from a referring hospital. Say, how's the fetal variability been going with the heart rate? Has there been some decent variability, especially during the contractions? And that statement saying it's the single most important factor in predicting fetal well-being, that might be an exam question in some of the certification tests for the flight nursing or the flight medic certifications. Decreased variability in the heart rate can be due to the following. The kid's hypoxic. It could be from the drugs that maybe the mom was taking on her own, or maybe some of the drugs that they gave at the referring hospital. If the kid's extremely premature, it's not going to have that same variability. And if the kid is asleep, that's fine. And there might not be much variability until he wakes up or till you start moving mom around. Fluctuations of the fetal heart rate actually reflect an interaction between the sympathetic and the parasympathetic branches of the autonomic nervous system. So short-term variability is considered the beat-to-beat irregularity is said to be either absent or present. And that's actually, I don't think you would actually see this, but just as nice to know, it's dominated by the parasympathetic branch. Since the parasympathetic branch is more susceptible to hypoxia, the absence of short-term variability may be the first sign of hypoxia. So you may not have to remember everything behind that as far as it being part of the parasympathetic nervous system and all that. But just remember, if they're telling you at the referring hospital there's really no short-term variability, just kind of keep that in the back of your head. There might be a problem with hypoxia. Long-term variability, it's mainly controlled by the sympathetic part of the autonomic nervous system. It usually varies 60 to 25 beats above or below the baseline fetal heart rate, which is that average fetal heart rate that they determine at the referring. And if there's the variability is greater than 25 beats, that can also be another sign of hypoxia for the baby. And the long-term variability can be considered absent or present also. Accelerations, as is accelerations in the variability, are above the baseline and they're usually associated with fetal movement or contractions. A fetus that is hypoxic and has metabolic acidosis is actually unable to accelerate its heart rate. So if you see a kid that during contractions, they're telling you at the referring hospital, hey, why mom's having contractions and the heart rate didn't go up at all in the kid, or the fetal heart rate didn't go up during contractions, that could be a pretty ominous sign. That's something you want to think about, that maybe things aren't going really well for the fetus at that point. Variable decelerations can occur anytime during contraction, and they're actually usually due to compression of the cord as the uterus is contracting and pushing maybe the kid's head up against the cord. There actually can be greater compression of the cord after rupture of the membranes. That's when all the fluid's out, so there's not that cushion there, so the kid's head might be pressing right up, or the body pressing right up against the cord, right up against the uterus without any of that cushion of the extra fluid there after the membranes have ruptured. Late decelerations begins at the peak of the contraction and with a gradual deceleration followed by return to the, a slow return to the baseline or the average fetal heart rate for that baby. It could be caused by uteroplacental insufficiency, which maybe there's not enough vessels that are still attached to transport the blood and the oxygen back and forth, which means there might be just inadequate oxygen exchange in the placenta, especially during a contraction. In the more severe cases with late decelerations, myocardial depression will be so severe that the heart is unable to decelerate in response to the stress of a contraction. And a very subtle deceleration of the fetal heart rate on the monitor or on the paper, it's going to look nearly flat, or essentially no change with the fetal heart rate baseline. Some more about the late deceleration, some of the additional causes can be caused by diabetes, cardiovascular kidney disease, if the fetus is past maturity, if mom's still smoking, any reason for decreased perfusion to the placenta, like a placenta previa or a placenta abrupta, a uterine hypertonus, which just kind of from the word just means that the uterus is so clamped down, the blood just can't get from the uterus to the placenta. And sometimes that can happen from the oxytocin, or what most people call pit or pitocin. Sometimes that can happen. Early decelerations, they begin at the very close to the beginning of the contraction and close to the end of the contraction. And it's caused by vagal stimulation from compression, from head compression during the contraction. This frequently occurs during labor, and it's more when the cervix is dilated to about 4 to 7 centimeters. Sinusoidal wave pattern. This is a uniform sine wave pattern. That means the pattern on the fetal heart rate monitor is going up and down in a very uniform motion. And it stays, it kind of keeps repeating itself. So the actual variability is absent. And it indicates fetal hypovolemia or anemia. And once it's recognized, a rapid delivery is recommended at this point. However, there's what they call a pseudo-sinusoidal pattern, which may be linked to maternal drug administration and may resolve on its own or with proper supportive care. So if we're at a referring hospital, we're up on their OB floor, and they're saying it's definitely a sinusoidal wave pattern and there's no variability on the fetal heart rate monitor, that might be something we want to be discussing with the staff there and the physician there. Do we really want to transport mom at this point, or do they need to deliver that kid there and maybe start having our NICU team heading up to that hospital, wherever it might be? We may even want to call back to the accepting physician back here at Lehigh and say, hey, maybe you need to have a talk with their doc and maybe work something out. Maybe we shouldn't be transporting this kid while he's sick. They need to speed up the delivery. Maybe they need to do an emergency C-section. But it's just something we need to be aware of. We don't want to be pushed off with something that they just want to get out of their doors, for example, just because they're afraid there might be a bad outcome. So just, it might be a conversation we might need to start when we're, especially if we're pretty far, from the receiving hospital. Bradycardia, so anytime we have fetal heart rate that's less than 120, not just for a few seconds, but if it's like that, the actual definition is for more than 5 or 10 minutes, or for 5 to 10 minutes. So if we get a fetal heart rate, even while we're transporting, and it's below 120, and we keep checking it, and it stays like that for a good 5 minutes or so, that means that there might be some hypoxia going on with the baby, more of a chronic fetal hypoxia. Just a caveat to that is if it's a past mature fetus, may end up having a baseline between 100 and 120. So if the kid's really overdue, for example, and it's somewhere between 100 and 120, and the staff at the referring is saying everything else looked fine, we might actually be okay with that. Maybe you just want to call back to double check, but just something to think about. For fetal heart rate for tachycardia, that would be greater than a fetal heart rate of 160 for 10 minutes or more to officially say the fetus has tachycardia. Now you could say, oh, I was a little tachycardic, but then we listened again with our Doppler a couple minutes later and the heart rate was below 160. So it might not be as alarming, and that might have been tachycardic maybe during a contraction or when the kid was moving around. So tachycardia is usually more of a compensatory mechanism to a more transient hypoxia, not a long-term. So a long-term hypoxia for an infant, the kids will tend to be bradycardic. A more short-term, they might become tachycardic for a while. Indicators for fetal well-being. What we're hoping, even when we're doing those quick trips from one of our own facilities to another, it's just a 10-minute ambulance ride with a healthy mom. The reason we're checking the fetal heart rate of our own is we're hoping it's going to be between 120 and 160. Now, for us, are we going to know if there's variability present for like an ER transfer that doesn't have that capability to constantly monitor the infant's fetal heart rate? We might not know the answer to that, to be perfectly honest. Or especially if we're picking up at a scene. Maybe we restify a patient from a scene that's a known high-risk OB patient. We're probably not going to be accurately say is there going to be a variability or the changing heart rate. It's when we go, once again, to the referring hospitals that have an OB floor. And if accelerations are present, that's actually kind of okay. And it means that the metabolic acidosis can be ruled out for the kid if there is some accelerations going on with the variability. A significant increase or decrease in fetal heart rate baseline in a few hours is considered a poor sign. So when we talk about a fetal heart rate baseline, we're not talking about the heart rate going up maybe an extra 30 or 40 beats just for a few seconds or a minute or two. We're talking about like over a 10-minute period, or when there's an average of a 10-minute period, that there's a significant increase or decrease. A decrease in variability as labor progresses is also a concern. We hope to see the heart rate changing pretty often. Bradycardia and tachycardia with reduced variability is also a poor sign. So if we see some bradycardia and tachycardia, but the heart rate is still varying pretty much of the time, that especially when they're monitoring at the referring hospital, that's probably okay. But when it's sustained bradycardia or sustained tachycardia, that's not a good sign. Variability is part of the assessment for fetal distress. So we talked a little bit about the late decelerations, and it's not extremely important that the flight crew or the transport crew is aware exactly what late decelerations are. We did discuss that a little bit earlier. But if the OB floor where you're picking up the patient says, oh, we've been seeing some late decelerations, especially if it continues to decline after a contraction, that's a pretty ominous sign for fetal distress. And when you hear the term fetal distress, that means the kid should be delivered immediately. That means if the kid's not going to be coming out the normal way, it's usually indicated to do an emergent C-section. So again, that's one of those cases where they say they use the buzzword fetal distress or continued late decelerations with the fetal heart rate variability. That's something you might not really have a discussion with their attending there, and maybe get one of our attendings involved in that discussion and say, you know what, maybe this kid needs to be delivered right here. We need to get the NICU team rolling. So, and we already talked about the same thing with the sinusoidal pattern is also considered a sign of fetal distress. So anything that's a sign of fetal distress, or you hear them saying fetal distress, there really should be discussion going on before you throw that kid, the mom, into the ambulance or the helicopter, especially for somewhere that can do a C-section. Possible causes of fetal distress: a cord prolapse, and something I didn't always know, a cord prolapse, it might not even be visible. A placenta previa or placenta abrupta. A hypertonic or tetanic, or basically two force valve contractions, can cause fetal distress. If that uterus is clamping down too much on the kid or pushing the kid too hard against the cord, that can cause some fetal distress because there's not enough blood and oxygen going to the kid during the contractions if they're just too strong. And as you remember, sometimes some of these contractions might even be induced from the medication they're giving, which would be the oxytocin or the pitocin, or some people just call it PIT. So that's something, I think any of the OB floors, they'll be looking at that. If they're giving PIT, they'll make sure that they're monitoring, of course, and they're going to look for stuff like that. Treatment considerations for fetal distress. You can maybe reposition the mom to a left lateral position, or you can even consider a switch to the right lateral position. Maybe taking some pressure off the mom's vena cava will increase the blood flow to the placenta. Maybe that will help. You want to discontinue the oxytocin. And the oxytocin actually has a pretty short half-life of just three minutes. And if you really need to stop contractions for this, and there's other reasons we might want to stop contractions, giving terbutaline, usually sub-Q, is something you may want to consider to stop contractions. Other treatment considerations: initiate or change to high-flow oxygen, and then also a fluid bolus, even if hypovolemia is just suspected with the mom or the kid. Postpartum hemorrhage, that's one of the complications we might see, and maybe this is from a mom that we're picking up, maybe from an ER that doesn't have an OB service, and it's defined, in case you happen to see this on an exam somewhere, it's greater than 500 milliliters of hemorrhage after delivery. And it usually occurs in the first few hours, but interestingly enough, can occur up to after 24 hours. And there is a certain amount, and there is technically 5% of all deliveries, there is some postpartum hemorrhage. So with approximately 5% of all deliveries, 5% of those moms are going to lose more than 500 milliliters of blood. Some of the predisposing factors to a postpartum hemorrhage might be an overdistended uterus, which could be caused by multiple gestations if there's more than one kid there. Maybe there's a tumor there, or maybe there's a history of fibroids, for example, or they're saying the fetus is really large. If they're saying it's a 9 or 10 pound kid or something like that, you might want to think along the lines, well, there's a possibility we could end up with a postpartum hemorrhage. An incomplete separation from the placenta to free from the uterus. So normally the placenta is expelled, within 5 to 20 minutes after delivery. But if not all the placenta comes out, it will continue to bleed, or often that will be the case. Another predisposing factor to a postpartum hemorrhage would be placenta previa or placenta abrupta, multiple parity, a past history of a postpartum hemorrhage, and also use of labor stimulants increase the risk of postpartum hemorrhage. So in a way, the same thing they're using to maybe stimulate the pitocin to stimulate labor might actually be the cure if they're bleeding a lot. Your abdominal palpation may reveal a soft uterus after the kid's born, and the problem itself may cause a worsening effect of the whole process. So when the clots fill the uterus, it makes it difficult for the uterus to contract and retract as it normally would to slow down the bleeding. So it can be like a vicious cycle when the clots start to fill the uterus, and the uterus can't clamp down the right way. A lot of times for postpartum hemorrhage, fundal massage is all that may be needed. And then you consider a rapid infusion of 20 to 40 units of PIT mixed in 100 milliliters of LR. I know we only carry 10, so maybe if you only got 500 in the bag, for example, that might be something, you might just throw it all into there and just run it in fast, I would say. Might be your best bet if you decide to go with the PIT, if the fundal massage isn't working. A precipitous delivery, and that's a delivery that's normally rapid with strong contractions and rapid cervical dilation. And usually occurs, pretty much what the definition is, if the delivery happens within 2 hours of the start of contractions. So some of the complications, so let's say we're picking up a mom at a referring hospital and she delivered in their ER, and we're actually picking up the mom, or maybe from a scene. So we want to think about the complications, say, you know what, this delivery happened within 30 or 60 minutes or less than 2 hours from the time the contraction started. So we want to think of things like, yeah, there's a possibility that she could be hemorrhaging more, there could be lacerations, externally and internally, there could be an embolism, there even could be a uterine rupture with those type of deliveries. So this is someone to keep in the back of our mind when we hear it was a real quick delivery. It could be umbilical cord prolapse with a real quick delivery. An overt cord prolapse is one that's pretty much visible. May not even be visible externally, but at least slip down into the vagina of the cord. The occult is when the cord prolapses, but you might not even know, and whoever's doing the vaginal exam might not even realize that the cord did prolapse. So it might not always be visible or even be able to palpate. So it's just something to think of, that you actually can have a cord prolapse that might not be visible. Treatment for the prolapsed cord is to keep the pressure of the presenting part off of the cord, and it may require to actually stick, hopefully with sterile gloves, a gloved hand in to keep that part off the cord. You may need to keep mom in a Trendelenburg or knee chest position, and you may need to use terbutaline to stop or slow the contractions, which hopefully will reduce the pressure on the cord. Placenta previa, that's when the placenta covers the opening to the birth canal. Bright red bleeding with little abdominal pain. Some of our treatment options, there should be no vaginal exam, and consider use of medications to slow contractions. And we want to monitor the fetal heart rate and also watch for DIC, which can happen. Placenta abrupta is characterized by more of a dark red bleeding with severe abdominal pain. The placenta tears away from the uterine wall, and the problem can be relatively minor or very severe. Treatment options, mainly in our environment at least, are essentially the same as placenta previa, especially when this is happening during labor. Uterine rupture, it's a very severe acute pain followed by no pain with vaginal bleeding. So if you have somebody with a lot of pain or some bleeding and everything else going on, and then the pain goes away, that might be your cue that could be a uterine rupture. And unfortunately, the fetal heart tones will be absent at that point. Treatment for a uterine rupture will be rapid transport for surgery. You might want to consider some PIT, the 20 to 40 units, and 1,000 bag of fluid to help slow the bleeding. Administration of course, fluids and blood products. Some of the other pregnancy complications, we have our pregnancy-induced hypertension, which could lead to preeclampsia or eclampsia. So hypertension that's pregnancy-induced is anything greater than 140 over 90, May include edema and protein in the urine. Signs of eclampsia or impending eclampsia: mom will have a headache, may report some visual disturbances, some epigastric pain, and the reflexes might be hyper, and maybe signs of renal failure, and that's where, especially if we're picking them up somewhere, hopefully they check the creatinine and the BUN. The HELP syndrome, this has to do with our eclamptic patient. So when we talk about hemolysis, it means there's problems going on, or hemolysis, that's problems going on with the liver. There'll be an elevated bilirubin, elevated liver enzymes, and then a low platelet count, which of course can be a problem for your bleeding later on. Treatment for your pregnancy-induced hypertension. Of course, we're going to continue to monitor our vital signs and the fetal heart rate. If possible, and this is what they're going to do in-house somewhere in the OB floor, monitor for late decelerations and decreased variability, which could be a sign of fetal distress. We talked about that a little while ago. High flow oxygen. You may want to consider the use of labetalol, 20 milligrams at a time. We push that over a couple minutes. We don't really want our diastolic, we'll stop giving it when the diastolic goes below 90. And if we're picking somebody up from a referring facility, they may have received some hydralazine from the sending facility. Signs leading to eclampsia. We can start with some mag sulfate, give 4 to 6 grams over 20 minutes, and then it's followed by 2 grams an hour infusion. They're saying this should be, the deep tendon reflexes should be depressed at a therapeutic level. I'm not sure how well we're going to really be checking those or how familiar we are with that. Probably what's more important, they say deep tendon reflexes are absent. The mag sulfate level is toxic. Well, again, we might not be real familiar with that, so maybe we're making, for a mom who's receiving mag IV, and we're looking at her, and now she seems to be becoming somewhat obtunded, decreased mental status, and everything else is kind of okay, like her blood sugar and her blood pressure and all that, but now she's, becoming difficult to arouse. That's when we're thinking that the mag level might actually be toxic. So if we strongly suspect that there is a toxic level of the mag, we would actually give calcium gluconate 1 gram over 3 minutes, maybe a longer period of time. And at that point, we should probably be talking to somebody, one of the attending physicians about that, if at all possible. Seizures caused by eclampsia, it's mag sulfate 1 gram a minute, so the seizure stops up to 4 grams. So if we have this eclamptic mom, she's seizing, it's up to 4 grams of mag, given 1 gram a minute. And then we follow that with 2 gram an hour infusion. And then we'll give up to 10 milligrams of Versed if she's still seizing. Probably, with the mag, that's helping to treat the cause, and it's probably a little bit less harmful for the baby if we can, stop the seizures with the mag. But if we need to use the Versed, then that's what we need to do, because mom continually seizing isn't going to help the kid any. If a mom does die from being eclamptic, it's actually a result of secondary hemorrhage, secondary from the seizures. So what that's telling me there, if mom dies from being eclamptic, it's going to be actually from her seizures causing a cerebral hemorrhage. I got to believe those are pretty violent seizures to cause that type of cerebral hemorrhage. The LOCK acronym for general treatment of the high-risk OB patients. We always place our high-risk patients, or anybody in the third trimester, in the left lateral position, or at least with a bump under their right hip, so they're at least leaning towards the left. We want to remember our oxygen, and we want to correct or improve contributing factors. And we want to keep reassessing fetal heart rate and intervene when indicated. We talked about some of the medications already. Go over a little bit of the dosing again. Terbutaline is 0.25 milligrams sub-Q or IV, Q 15 minutes for preterm labor. And that's when there's a pretty urgent need to stop or slow contractions. So when we're giving the terbutaline, it's actually a pretty big step to do, and a lot of times they don't like to really do that on the floor unless they really have to. So if you're going to that, that's kind of a big move. But if you absolutely need to stop contractions or slow them down, that's going to be probably going to be your medication of choice. Some places will, a lot of times they'll use mag sulfate, and then they'll follow that by a drip. The slow contractions also can be used for that. For seizures, we already talked about that. Just to review, 1 gram a minute up to 4 grams, followed by the infusion. The Pitocin, sometimes we'll see this when we're picking up a patient. Called oxytocin, Pitocin, or just Pit for short. And they'll usually, if they're using it to induce labor, they might just throw 20 to 40 in a 1,000 bag and they'll infuse it about 125 an hour. They'll infuse it more rapidly for a hemorrhage. Now, to me, if we're picking up somebody that's on PIT and they're using it to induce labor, probably going to want to think about the logic of that. Do we want to load somebody in the helicopter or the ambulance that's receiving PIT or Pitocin to induce labor? Maybe we want to kind of stop the labor process, if at all possible, while we're transporting that patient. Or maybe we just need to stay at that other hospital if there's a need for the fetus to be delivered, emergently. So I'd be real leery if we're trying to push off a mom that's receiving PIT and she hasn't delivered yet, because that's just going to make the delivery go that much faster. And I think if at all possible, we want to avoid having to deliver in the helicopter or the ambulance or along the way. Hydralazine, we might see this used for the patients we pick up. It's used to treat the pregnancy-induced hypertension, like your preeclamptic patient or your eclamptic patient. It's 2 milligrams IV over 5 minutes, and they usually try to keep the diastolic blood pressure down around 90 to 100. And then there's, just for nice to know, 5 to 10 milligrams every 20 minutes with some parameters. Labetalol, something we might use for pregnancy-induced hypertension, especially if there's some symptoms really going on or some signs of the patient being preeclamptic or eclamptic. And it's 20 milligrams over 2 minutes every 10 minutes. And we don't really want to lower the diastolic less than 90. And the max dose is 300 milligrams. I would hope in the transport environment we're not with a patient that long that we're giving 20 at a time to get up to 300 milligrams. Now, maybe there's a chance they got some labetalol beforehand, but hopefully we're never in that position where we're maxing out on labetalol on any of our patients. Just a little bit of a discussion on the blood volume of a 3rd trimester patient or the mom. There's actually a 50% increase in the plasma from normal. There'll be like an 18 to 30% increase from the RBCs. And here's something really interesting that you want to really keep in mind when we see these moms that might be traumatized. A maternal blood loss can be the point of not showing any signs of elevated heart rate or low BP and still result in a reduction of 90 to 95% blood flow to the fetus. So that means that there can be up to 90 to 95% reduction of blood flow going to the fetus before the mom even shows any signs of shock. So if we're at a scene, or even if we're picking up somebody in their 3rd trimester from a referring ER or maybe OB floor or whatever, we want to keep that in mind. If we think mom is bleeding or hypovolemic for whatever reason, there can be a lot of blood flow that's not going to that baby before the mom shows any signs. So we need to keep that in mind. So we need to be pretty aggressive with our fluids or even blood if needed, for any blood loss for the mom. Of course, we want to avoid use of vasopressors in the pregnant patient. It's just going to cut down on the blood flow going from the uterus to the placenta. And probably a lot of other bad things too. Third trimester patients are more likely to vomit than normal, which makes a lot of sense. Everything's being pushed up against the diaphragm, especially if they're pretty flat. Statistically, trauma is the most likely cause of mortality to a pregnant patient. So overall, if a pregnant patient's going to die, it's going to be from trauma, statistically speaking. So we need to keep that in mind when we pick these ladies up from a referring ER or an accident scene. Placental abruption is the leading cause of fetal death in the trauma. So if you remember with the placental abruption, there's going to be a dark blood and there's going to be a lot of lower abdominal pain with that. A relatively minor mechanism of injury may cause the placenta to tear up on the uterine wall. So even if mom doesn't seem that hurt, the vehicles don't look too bad, it doesn't mean mom needs a helicopter ride every time there's a mom involved in a minor car accident. But any mom any pregnant mom should be going to the hospital to be checked out, even if it's not in the most urgent sense. They need to go to the hospital and get checked out.